Okay, perfect. Welcome back. Week 10, PS Pain Relief. This week we'll be covering pharmacology, wound healing, and microbiology. Hope everything's been going well and things have been making sense, and hopefully these will be helpful for you today. I'll be taking the first part, pharmacokinetics, within pharmacology. So I remember when I was studying pharmacokinetics, it confused the hell out of me. I had no idea what it was, and I could barely remember the difference between pharmacokinetics and pharmacodynamics. So hopefully after this, it clears up some of that stuff for you guys. If you still have questions, just let any of us know. Let me know. Christine, you can just find me, message me on Facebook or whatever you want, and I'm more than happy to answer any questions you have here. Okay, so pharmacokinetics, the main things I want to be covering within this is going to be drug administration. So how do we administer a drug? How does it enter our body? Yeah, how does our body first meet the drug? The second thing is going to be the phases of drug action. So that's split into three different things. You've got pharmaceutical phase, pharmacological phase, and the pharmacokinetic and pharmacodynamic phase. So those three. The pharmaceutical phase is pretty much, how do we release the drug from the package? How does the drug and the body first meet? Pharmacokinetics split into four different things. You've got absorption, distribution, metabolism, so biotransformation, and excretion. So that's going to be, I guess, what does the body do to the drug? Or how is the drug treated by the body? That's what pharmacokinetics is. Okay, so we absorb the drug, distribute, so spread it amongst tissues. We metabolize, so do we break it down? Do we transform the molecules? And then we excrete it. And the last one's pharmacodynamics. And that's what the drug does to the body. So what are the drug's effects on the body? So that can include binding to target site and the stimulus and effect of the drug. In essence, these 2 dot points can be summarized by these 2 diagrams over here. Administration of the drug into the body. There's a couple ways you can do that, and also what does the body do to the drug once the drug's inside? So we'll absorb the drug at the stomach and the small intestine, and it enters the bloodstream, right? Within the bloodstream, it's distributed to tissues. It'll go to the liver and kidneys and other things, where it'll be metabolized. So we're biologically changing the drug. We're doing a couple things to the drug. We might be adding things to it, breaking the drug down a little bit. And then last of all, we excrete the drug via our feces, via urine, and even through your breath. Okay, so first of all, starting with the administration of the drugs, you've got parenteral, just means injections. It's helpful because it's got a rapid onset. For example, if you put a drug straight into your veins, IV, then the drug has an immediate effect, right? It's super rapid onset. You can also inject it intramuscularly. You also have subcutaneous injections. Don't use this to remember, but this is what I used to remember. I know that IVs like really, really fast because I think to myself, a lot of like illegal drugs, they'll inject via, IV, right? They'll inject it into one of their veins, and that's so they can get an immediate effect of the drug. It's the same thing pharmacologically. If you use an IV drug, it enters your bloodstream immediately, right? So it doesn't do any of the other stuff. It doesn't have to do anything. It's already there. Versus oral, if you take it by tablet or pill. Sublingual, we're putting the drug underneath the tongue, and the benefit of that is that it can bypass the stomach acid and the gut enzymes. Intranasal sprays you might have used for hay fever or something like that. Transmucosal, so across your mucosal membranes, like the vagina. Rectal is actually really helpful too, especially for emergency delivery of drugs. And you've got transdermal, so this is topical. A lot of creams you can apply topically, antifungal creams, a lot of steroid creams, Histone, Elicon, straight on the skin. But the preferred route is by far oral. And there's benefits to oral because patient compliance, patients are more likely going to do it if they can just take a tablet and forget about it, versus if they had to inject themselves on their belly fat or whatever, right? However, not all drugs can be administered via the oral route. And so these kind of drugs would be the more unstable drugs that would get degraded in the GIT by stomach acid or those gut enzymes we've mentioned. If a patient's unconscious, they can't physically take a drug, right? You can't make them swallow the drug. That's dangerous. If a patient's vomiting, the drug won't have enough time in the stomach and in intestines to get absorbed, right? And so it it exits the body before it even gets absorbed. And you can't take a drug orally if the systemic effects are too severe, so if it's too harmful. Okay? So again, I want to give a big shout out, like big creds to Marianne here. She made this diagram like from scratch and stuff. She made a lot of content for the Pharmacokinetics on accident, but I've tried to keep and use a lot of the materials she's created as well. And this is really great. She made this, and it's kind of nice. I'm showing you the steps from ingestion, how the drug enters your esophagus, your gastrointestinal tract, so absorbed in the stomach, in the intestines, and then it enters the bloodstream, goes to the liver where it gets metabolized, enters systemic circulation, goes back to the circulation, reaches your target organs, and you've got that metabolism and excretion as well. But yeah, why does pharmacokinetics matter? I guess apart from the importance of knowing what happens to the drug once it enters your body, it also matters because you need to know about pharmacokinetics in order to know about dosage. How much dosage should you give for a patient so that it's effective, but it's not too high that it's going to cause harmful effects. So it's not too high that we're going to have adverse events, okay? So that's the importance of pharmacokinetics. And I think it has a lot of real applications. It's just a bit confusing sometimes. But again, just another slide kind of giving you the overview. You've got the 4 steps: absorption, distribution, metabolism, and elimination. Now I've kind of popped in italics some of the key points we're trying to cover under those. So I guess to start us off with, absorption. So a couple methods of absorption. A drug can be absorbed via passive diffusion, facilitated diffusion, you've got active transport, endocytosis. Hopefully you remember this sort of stuff from biology or the bridging course or whatnot. But yeah, passive diffusion, the drug enters the membrane via channel protein or a pore, or it can go straight through the plasma membrane. You've got facilitated diffusion, which is aided by carrier proteins, and you've also got active transport, which is energy dependent, so it requires energy to incorporate and take that drug into the cell, and that means you require ATP. So you hydrolyze ATP to form ADP. The last one is endocytosis, and we use endocytosis when the cell membrane engulfs the drug because the drug's just too big. It's too big to diffuse or go through a channel protein or whatnot. So we physically engulf the drug to help it enter the cell. So those are the methods of absorption. In terms of the factors affecting absorption, there's a couple. So there's pH that can determine whether a drug is ionized or in its unionized forms. The drugs will come in 2 forms, either ionized or unionized. When I think of unionized, I try to think of it's more lipophilic, so fatty, no charge, it's non-polar, which makes it more easy to enter the tissues because our tissues have a overall non-polar plasma membrane. So, like attracts like, if it's in an unionized form, it's more likely and easier to enter and absorb into your tissues. A couple other things, you've also got the blood flow to your organ, which will affect that absorption. So increased blood flow increases the amount of drug delivered to that area. So now that I've said that, it's good to mention bioavailability, and I'll be showing you as well some plasma drug concentration curves. These square brackets means concentration. So yeah, what is bioavailability? It's essentially what is the percentage of the drug that actually reaches the bloodstream. Thinking here, unless we're doing intravenous drug administration, bioavailability is going to be less than 100% because meds get metabolized and cleared before they even reach the systemic circulation. But more on that just over this next slide now. Again, bioavailability is the measure of how much drug is absorbed into systemic circulation, systemic whole body circulation, so we're talking about the bloodstream, in comparison to IV administration. So IV administration would be 100%. Bioavailability is how much is absorbed compared to that intravenous administration. So for example, if we were looking at the bioavailability of an oral tablet, so just right here, this little pink curve, you would compare it as the area underneath the curve for the oral tablet versus area underneath the curve for the IV dose, which you can see immediately as 100% bioavailability, like almost instantly, it's 100% bioavailable because nothing happens to it. It's made its way directly into a bloodstream. In terms of the things which affect bioavailability, you can have a read. Most of my slides will have a couple, like 1 or 2 sentences, or maybe a little bit more detail in terms of the things I go on, in terms of the notes I go into. So just check out the speaker's notes. My help out. They're rough notes, but you can have a read of them if you want. But yeah, there's a couple of things which affect bioavailability. So drugs can get removed in the liver, or their absorption can be delayed in the GIT. That could be because of lipid solubility. So how soluble are they in fat? You've got the rate of dispersion. You've even got gastric emptying, so your stomach emptying. A lot of different things, pH and intestinal drainage, right? But basically, the idea is that drugs aren't instantly bioavailable. They have to cross some membranes before they can enter the bloodstream. And for some of them, it takes a while before they enter the bloodstream at a decently high level, like you can see here with this oral tablet. And again, you can plot this over a graph, and it's important to know bioavailability because it helps you determine the dosage and the effective therapeutic concentrations. So the overall principles of dose, we've taken this pink graph here, yeah? We're having a look at it. So it's plotted over time, and we're having a look at the plasma concentration. So what is this drug's concentration in the bloodstream or in the blood plasma? See, it takes a while before it reaches its peak of effect, right? Now, drugs will also have a minimum toxic concentration. So what concentration do they need to be before they start becoming really toxic to the body, and a minimum effective concentration, below which they're not going to do anything for your body. They're going to be subtherapeutic. They're not going to actually improve things or work about their target response if they're underneath this concentration. So basically, the therapeutic window is right in the middle. High enough that we're doing something effective, we're helping the body out, but not too high that we're starting to cause adverse effects and we're starting to harm the body, with this lovely green window here. And the goal is we want to keep our drug plasma concentrations within this therapeutic window, so within this therapeutic range, okay? Therapeutic index, so it's minimum toxic concentration over minimum effective concentration. If you've got a really, therapeutic index can help indicate to you how easy it is for a drug to be taken, in the way that, like, how finicky is a drug? Is it between a very thin therapeutic range, or is there a lot of leeway with this drug? It's going to be effective, quite low, and it's not going to become toxic until quite a high concentration. That's kind of what these are talking about. Hopefully these equations kind of make sense to you. Duration is the time that a drug spends above the minimum effective concentration, and the onset time is the amount of time it takes for a drug to reach that minimum effective concentration. Really important thing here to note is that with the principles of dosage and how it increases and it decreases over time, we need a dose at regular intervals, right? Because what that's going to do is it's going to maintain our bioavailability, and it helps us stay within that therapeutic range. So if I just drew that out, often what will happen is you'll see graphs where you'll see a peak, right? And then before it drops too low, patients will take a drug again, and it'll keep going through this peaking window, and it looks something like this, right? That's kind of what it looks like. Very artistic, I know, I'm sorry. But that's in order to keep that drug within that therapeutic window. Now, for some drugs, you can take once a day and it'll maintain itself within that therapeutic window for a while, right? Whereas others, it's a bit more finicky. It has to be, 3 times a day. And that's because those peaks, we're really trying to keep that peak within the therapeutic windows, because we want to stay within the green as much as possible, if that makes sense. Keep the drug effective, but not too high that it's going to be harmful. Okay? So that's absorption. Next, we've got distribution. Distribution is pretty much, you've absorbed the blood into your bloodstream, right? But now you want that drug to reach your target organs. A couple of factors which affect distribution of drugs. And again, I've got a bit more detail in the speaker notes. If you want to check that out, it'll be able to help you if you're taking physical notes or whatnot. But yeah, the factors affecting drug distribution include the ease of diffusion out of the drug vessels. If it diffuses easily out of the blood vessels, it's going to make it easier for it to reach its target organs. If it delivers easily to the tissues, again, increasing the distribution. If it binds easily to target tissue components, also increases that drug distribution. And overall, I just wanted to make a quick note, lipophilic drugs, so fat-loving drugs, have a greater distribution than hydrophilic drugs. Hopefully you're able to kind of logic that out. lipophilic, so fat-loving drugs, are kind of the same charge and whatnot to our plasma membranes inside our cells. It makes it easier for them to diffuse past and enter tissues, enter the to exit the circulation, enter the tissues, enter our cells. Another big thing is albumin. If you don't know what albumin is, it's the most common blood-bound protein. And what happens is it has a really large role in drug distribution because a lot of drugs will bind to plasma proteins. Now, in order to bind to a target organ or reach your target organ, the drug actually has to dissociate from albumin or from the plasma protein. So if a drug has a high affinity to albumin, it slows the drug distribution because that means it's harder for the drug to unbind to albumin and therefore go and diffuse and bind onto the target organ. So a high affinity to albumin will also slow drug distribution. Some other things I've got written in the notes are blood flow. So if an organ receives more blood flow, there'll be more drug distribution to that organ. Same thing with capillary permeability. So that's the idea. How easy is it for the drug to diffuse out of the blood vessels? One thing I've decided to pop in for you guys as well is the volume of distribution. What is the volume of distribution? It's the amount of drug in the body over the drug concentration in blood plasma. Again, I've got some rough notes, a bit more on that in the speaker notes if you want to have a read up on that. And I've also popped in a little bit about low molecular and high molecular weight for drugs, right? But the key thing with volume of distribution, again, is it helps estimate drug dosing. If there's a high volume of distribution, you won't need to administer as high of a dosage to get desired levels, right? Okay, if I repeat that again, if there's a high volume of distribution, it makes it easier for the drug. So the drug enters the target organs, target tissues really easily. It doesn't, just stay in the blood plasma and then gets eliminated. It enters the blood and then goes straight to where it needs to be, high volume of distribution. So if you've got a high volume of distribution, you won't need to administer as high of a dosage. Again, that's in the notes if you want to rehash over some of these ideas as well. Alrighty. Next thing, talking about metabolism and elimination. So how a drug's eliminated, that's the idea of clearance. So metabolism is the biotransformation of a drug, right? So there's a couple of ways you can do it. So there's liver, gut, and kidneys. So it's the hepatic, biliary, and renal route, respectively. The overall idea, if you only remember one thing about it, is that with metabolism and biotransformation of drugs, we essentially are trying to make lipid-soluble drugs more water-soluble. If they're more water-soluble, it's easier for us to excrete them in our urine, which is the main way we excrete drugs. And it's this step right here, and this one up here. What is first pass clearance? It's the extent to which a drug is removed by the liver during its first passage through the liver into the systemic circulation. Okay, so how much of the drug is removed in that first pass? That's what first pass clearance is. In terms of excretion, it'll be via the urine, feces, bile, lungs, a couple ways to do it. And tissue redistribution via circulation will occur with the resting blood flow. Now, its effects are diminished if you have a lower resting blood flow. And I think my hand's just got it in this nice diagram right here. The first pass clearance, excretion, returning to liver and reaching kidneys. Alrighty, now I will quickly mention a little bit about the biotransformation which happens at the liver, because the liver is the main organ which kind of detoxes or deals with the drugs, right? So the liver has two reactions. It's got phase 1 reactions and phase 2 reactions. Phase 1 reactions basically introduce or unmask a hydrophilic group. I wouldn't stress too much about it. What I remember for phase 1 is cytochrome P450 enzymes. Okay, cytochrome P450 enzymes are a family of enzymes which have a broad substrate specificity, and it's the enzyme to remember because it has a role in drug metabolism, phase 1 drug metabolism. Now the liver also has phase 2 metabolism, which has conjugation, which is basically where we add polar components, so water-soluble components, onto a drug, which makes it harder for a drug to diffuse across a membrane, makes it easier for the liver to eliminate that drug from the body. Now, drugs can go either through phase 1 or phase 2 or both, but it's not necessarily sequential. Okay, so if you want to read up on phase 1, phase 2 liver metabolism, it's in the speaker notes. Okay, I feel like I keep plugging the speaker notes. Oh god. Okay, another thing I want to mention is the rate of drug elimination. So we'll have to talk about first and zero order kinetics. Kinetics is just movement, right? So there's two types, there's first and zero order. I'll show you a quick graph which should hopefully kind of clear it up for you, and I'll give you the buzzwordy exam stuff for it. So what is first order and what is zero order kinetics? Most drugs will undergo first order elimination. So it's the idea that the rate of drug elimination is proportionate or proportional to the concentration of the drug in the body. Okay, so yeah, same proportion of the drug is eliminated per unit of time leads to a variable amount eliminated based on the plasma concentration, right? So if there's a high plasma concentration, you're eliminating a lot more, right? But as the plasma concentration decreases, we also have a decrease in the rate of elimination. So you get this graph looking like this, okay? Now, second of all, you've actually got drugs which have a zero order elimination, which means that the rate of elimination is constant. The same amount of drug is eliminated per unit of time. Doesn't matter what the plasma concentration is, it's only going to remove that much at a time. And the main thing I want you to remember here, two things. Alcohol and aspirin, mainly alcohol. This is very examy, very buzzwordy. Alcohol is a common drug which has zero order kinetics. It doesn't matter what the concentration of plasma concentration of alcohol is, you're only going to eliminate it at that same linear rate. It doesn't increase, doesn't slow down. Another thing to mention is half-life. Half-life is the amount of time taken to reduce an amount of drug in the body by half. That should be just a bit of a recap from chemistry. And last of all, rate of elimination. What is the rate of elimination? It's drug clearance, Cl, times the concentration in free plasma. And this applies to the first order elimination only. Okay, I wouldn't fret too much about that if I were you guys, though. It's just there for completion's sake. Alrighties, now this is the last thing I'm going to be talking about, and that's steady state concentration and how half-life kind of has a role in there. So again, what is half-life? It's a time taken to reduce the amount of a drug in the body by half, right? And there's a couple of things we need to know. So what is steady state concentration? Yeah, this is what I want to, in my poor diagrams, my poor drawing before, this is what I want to show with the dosing, how you'll take a med here and it increases in amount, and then you take it again, increases, take it again, increasing. You can see how it starts to get metabolized, excreted, so it decreases in plasma concentration, right? And that's why it kind of looks undulating like a graph like that. Anyways, steady state concentration occurs when the rate of elimination for a drug equals the rate of elimination, okay? Sorry, not rate of elimination, rate of absorption. I'll fix that in the notes in a little bit. It's rate of absorption of a drug, okay? So this is normally about 4 to 5 half-lives. And that's, yeah, steady state. And this obviously has to occur above minimum effective concentration, but we also want it to be below minimum toxic concentrations, right? Okay, so yeah, again, idea that we want it to occur within this therapeutic range. Cool. So I guess the application here is that it's important to administer drugs at regular intervals to maintain their bioavailability and stay within that therapeutic range, okay? On that note, I've also wanted to mention what are maintenance doses and what are loading doses. So here, a maintenance dose is a dose given to a patient of a drug just to maintain the bioavailability, keep it within that range, so keep it around about that steady state concentration. Essentially, the dosage which is equal to the rate of elimination at steady state. That's what a maintenance dose is. So it's to maintain the drug plasma concentration. Maintenance dose maintains the drug's plasma concentration. Now, the loading dose is what you see first over here. And a loading dose is basically a high dosage, and it's used for drugs which are eliminated slowly from the body. And what this allows is it allows a plasma concentration to actually increase enough for that drug for us to actually reach the minimum effective concentration. And then after that, often people will use a maintenance dose to keep the drug concentration within that therapeutic window. But yeah, overall, that sums up the pharmacokinetics part. That's all from me. If you've got any questions, please let me know. Message me, so Christine Ewan, or you can find me on Facebook or message, email, whatever you want if you've got questions, okay? Hopefully this has cleared some things up. And the next part is anti-cancer drugs.
Hi guys, it's Vicky. I'm gonna take you guys over anti-cancer drugs this week. And remember, if you guys have any questions, you can always message us on Facebook. Yeah, I hope you guys are doing okay with all the content so far, and that's not too hard. Yeah, so I'm gonna go over cancer chemotherapy, I guess, and we're gonna start with a bit of a revision on the properties of cancer cells. So first is that they proliferate really rapidly, and it's important to note that some normal cells in our body also have really rapid turnover rates, such as cells lining our gastrointestinal tract or our skin cells, and this is why in a lot of anti-cancer drugs we'll see adverse effects in these other areas as well. Because they have like similar characteristics to the cancer cells that we're targeting, and that benign cancer cells grow slower, I guess, than malignant ones. I guess that's what makes them like less harmful. Yeah, and that cancer cells are primitive and less differentiated, so they're a bit similar to embryonic cells. Yeah, and their nucleus appears different. And they're kind of like liquid cells. They grow in different pathways or have different structure arrangements to what is normal, and they can turn off apoptosis. That's why they proliferate rapidly and endlessly. And their membrane surface might have some markers that's unique to cancers. So while they often retain some normal markers of like normal cells that allows them to avoid detection by our immune system, they can also have some markers that are like heavily or overexpressed on cancer cells, and we try and find those and target them as well. And then the methods of management, of course, radiotherapy, surgery, chemo, or like just supportive therapy like analgesics for the pain, antidepressants, and diet. And a diagram on the bottom right is kind of just a reminder of the difference between normal and cancer cells. Yeah, so cancer chemotherapy, anti-cancer drugs can also be called anti-neoplastics. And then there's the classic cytotoxic agents. So these are just drugs that have been around a long time and they're cheap, but they have really severe adverse effects. And then there are novel anti-cancer agents with less severe adverse effects. Yeah, and in bold, these are just the drugs that are on our core drug list, and I'm going to go over them at the very end. Yeah, and some things to note for cancer chemotherapy is that it could be curative as palliative. So, of course, like if we can no longer cure the cancer, if the stage is too severe, we can only try and relieve the pain and make lives as easy for the patients as possible. Yeah, and then for which drug we decide to use, we can do it based on in vitro testing. So we can culture different cancer cells and expose them to different drugs and see which one is more effective. Or we tend to use evidence of previous success. And I guess it's important to note that there's no strict oncology guideline on how to treat cancer like there is for like antibiotics and stuff like that. So I think what the lecturer mentioned was that you'll often find in many different countries or like even between hospitals within a country, the treatment regime is quite different based on just what has been successful for them, I guess. And yeah, there's a principle of selective toxicity. So I guess we should be familiar with this by now with all the farm stuff, but we're always trying to target as specifically as we can. So of course we only want to target the cancer cells. We don't want to target our normal cells. So we try and find differences between our cells, our normal cells, and the cancer cells, just to try and harm our body as little as possible. But so far there's no drugs yet that can do this. Instead we use like a relative approach where we target parts of cancer cells that our normal cells still have but are different. Yeah. And lastly, some drugs attack on different phases of the cell cycle, like they can be specific to a phase, such as like the replication phase or whatever. Yeah, and the thing is that cancer cells are heterogeneous, so they're never at the same phase. Therefore, when we take chemo, sometimes we can only target the proportion of cells that's at that specific phase, and then the rest we might have to wait for them to reach that phase in order for them to be targeted as well. And cancer cells at this G0 phase where they're not proliferating, we can't target them. Yeah, and this is just a diagram from ePharm to just show like all the different pathways that cancer drugs target, and only some of these are on our core drug list, and they're methotrexate, fluorouracil, and cyclophosphamide, and doxorubicin. I'm so sorry if I'm pronouncing the drug names wrong, guys. I'm so bad at this. Okay, so now we're gonna go over the classic cytotoxic agents. So remember, these are the ones with quite severe adverse effects. The first one is an alkylating agent. So the drug inserts an alkyl group into the DNA structure, and this causes like cross-linking, and these cross-linkings are covalent bonds. So of course, covalent bonds are irreversible. Yeah, so it could be like adjacent, or it could ideally be like like cross-linking or intra-strand linking. And especially these cross-linking, it makes the DNA strands unable to pull apart during replication, so it causes like stress on these strands, and they break, resulting in cell death. Yep. And they're cycle non-specific. Some can even affect the G0 stage. Yeah, and then next there's the cytotoxic antibiotics. So these are antibiotics that were originally intended for infectious disease, but they were found to be too toxic for the body. So they can inhibit transcription and translations. Therefore, the cancer cells don't have any proteins to grow, and then the immune system has a better chance of fighting it. And apparently they're very expensive, but they could also potentially cure cancer, so it's kind of like a cost vs benefit thing. Yep. And then there's antimetabolites. So they substitute into the DNA synthesis pathway. So I guess they're like molecules that are similar to the molecules that are found in the DNA synthesis pathway. So they block DNA synthesis or make the DNA non-functional, therefore the cell can't grow or they die. And there's multiple pathways that can be affected. Yeah. And so because they affect DNA synthesis, they're cyclospecific, they're S-phase inhibitors, and they're different subclasses. So some can affect pathways involving folate, or they can affect just the pyrimidines, which are the CNT bases, or purine bases, which are the ANG ones. Yeah, and the next kind of drug is histone deacetylase inhibitors. So apparently, HDAC is like an enzyme that's used in gene expression for intracellular signaling, cell growth, and cell death. So by inhibiting it, we can arrest the cell cycle progress, so the cell can no longer proliferate and grow, and then it triggers apoptosis, like cell death. Yeah, and apparently this type of drugs is used in cutaneous T-cell lymphoma, and it's a brand new drug, so it's actually a novel agent, but it has similar adverse effect profile as the classic drugs. That's why we like categorize them under this. And these are just some examples, but they're not on the core drug list, so I guess you don't really need to know them. Next is plant alkaloids. So yeah, they're drugs directly derived from plant chemicals, and they have like different ways of working. So some inhibit microtubule function, so that's why they're also known as mitotic poisons. So of course then they target the M phase, mitosis. They free cells in mitosis. The cells can't divide without these spindles, and then these are just some examples. Yeah, especially like taxane, which is from the European yew tree. And when we first found out, I guess we kept like like trees take a long time to grow. So in order to extract this, we apparently almost drove the tree extinct. And yeah, some inhibit topoisomerase. So if you remember your the biochem at the start of the year, this enzyme is used for the uncoiling of DNA during replications. Of course, if the cancer cells can't uncoil, it can't replicate either. And then lastly, there's like hormones and hormone antagonists. So these are especially useful for reproductive cancers because these tumors require sex hormones to grow as growth, like they require them as growth factors. And some examples of breast, prostate, and cervix cancer. So in breast cancer, there's like SERMs and aromatase inhibitors. Yeah, and these two are on the core drug list, so I'm going to explain them at the end when I go over the core drug list. And then for prostate cancers grow better in the presence of androgens, not really testosterone, but like other androgens. So of course we can have anti-androgens to reduce the tumor mass, or we can have something known as the gonadotropin-releasing hormones analogs. So gonadotropin-releasing hormones are produced by the hypothalamus to stimulate the pituitary to release LH and FSH, and these are just like the sex hormones. Yeah, and LH stimulates the testes to produce androgen. So when we take drugs in repeated doses at set intervals, we can somehow manage to trigger negative feedback in the body. So we lower the secretion of LH, and therefore we lower the release of androgen by the testes. And remember, androgen is what is needed for prostate cancers to grow. Yeah, and then there's also glucocorticoids. So they're cortisol-like drugs, and high doses of them can lead to lysis of affected cells. We cause the membranes to rupture and the cells to die, and apparently they preferentially target cancer cells. And they're useful in bloodborne cancers like lymphoma or leukemia. Yeah, so the common adverse effects of anti-cancer drugs are these, and it's just like a diagram to show some of them. So some can be associated with rapidly dividing normal cell populations. So remember how I mentioned this at the start, that some of our normal cells also have really rapid turnover rates, and they can be affected as well, and other ones are associated with like organ toxicity. So the ones with rapidly dividing normal cells, so they're our blood cells, our red blood cells, our white blood cells, our platelets. So of course, if we have lower red blood cells, we have anemia. If we have lower white blood cells, we have lower immunity, and we're more susceptible to infections, and lower platelets means clotting problems as well. And the way this is managed is by colony stimulating factors, CSFs. So they're just like, I guess, drugs that stimulate the growth of such as like white blood cells. So this can help with the immunity of the patient. And erythropoietin. Oh, I'm so sorry. And it can help anemia. Yep. And then for skin, our skin cells are also rapidly dividing, so it can cause blistering or extravasation. So that's when like the drugs leak out of the IV, and it can destroy the surrounding tissue. And apparently, it can also happen to clinicians as well if they're like not careful while administering the drug to the patients. And then there's our gastrointestinal lining. So this causes inflammation, and sometimes this inflammation can cause nausea and vomiting. And that's why to target these, we have antiemetic drugs. So antiemetic drugs are drugs against like nausea and vomiting. Yeah, and they're dopamine, serotonin, or neurokinin receptor antagonists. And these are some examples, but I'd say don't be too worried about these right now because you'll learn them in second year. And so these receptors, the dopamine, serotonin, neurokinin receptors, associated with the vomiting center in the medulla. That's why it causes nausea and vomiting. Yeah, and also dopamine and serotonin are also associated with the GIT wall. So not only does it have central effects, like on the vomiting center, it also has peripheral effects. Yeah. And another way to manage these is glucocorticoids, such as dexamethasone. So they're anti-inflammatory. So instead of directly targeting your vomiting center or whatever, there is trying to lower the inflammation. And when the inflammation is lowered, there is less sensory information to be sent to the vomiting center, showing that you want to like throw up and stuff. And then next is the mucous membranes. So it can cause mucositis, just inflammation of the mucous membranes. So it can cause stuff like ulcerated sores in your mouth. And then hair follicles, your hair falls out. I think we're like quite familiar with that, as you see in all these movies of people going bald because they're on chemo and stuff. And then lastly, there's like sick cells, like sperms or like and they can cause like infertility. So some patients may choose to donate or freeze the cells, before their treatment. Yeah. And for organ toxicity in the heart, it can cause acute heart failure or arrhythmias, so like abnormal heart rhythms, and this is especially in the elderly, which is kind of troublesome because the elderly are normally the ones with cancer. The kidneys can cause kidney impairment, and you should know by now that a lot of drugs are excreted by our kidneys, so it can increase like drug levels in our body. It can also apparently affect the nervous system. Because microtubules are needed in axons for transport mechanisms. That's why it can get stuff like paresthesia, tingling, numbness, and burning sensations. And in the bladder, the alkylating agents, remember that's the first drug we talked about, the classic cytotoxic agent, alkylating agents, can cause something called the hemorrhagic cystitis. So cystitis is inflammation of the bladder, and therefore we have lower urinary tract symptoms like dysuria, like pain on peeing, or like blood on peeing, and hemorrhage. Yep. And apparently we have a drug called Mesna for this, and it works by inhibiting production of metabolites and alkylating agents, metabolites that damage the bladder, so it inhibits that. Yeah, and now moving on to some of our more novel agents. There's the monoclonal antibodies. I'm not gonna go over the production of them because I'm pretty sure we learned that early on in the year in like the genetics topic or something like that. Yeah. So yeah, of course you should know by now they're antibodies that produce one specific antigen. Yeah, and they always end in MAB. So they're fast and apparently relatively cheap. But the problem with them is that they're animal products, so they may produce like immune responses in a patient or allergies and stuff like that. So it may be like rejected. And we can also even attach a cytotoxic agent to it. So it can target the cancer cells we want specifically and deliver these cytotoxic agents to them. An example is rituximab. Oh my god, I don't know. And apparently it targets CD20 that is it's an antigen called CD20 that's overexpressed on B cells and non-Hodgkin's lymphoma. I don't think you have to worry too much about this drug because this one's not on the core drug list. But I'm not sure. And then the next one is biological response modifiers. So instead of targeting the cancer cells, we try to boost our own immunity. And apparently they're expensive. So there could be interferons or IL-2, and these are of course like our signaling molecules. Yeah, and apparently these can have like three functions. First, they increase the cytotoxicity of our own immune cells, which are our natural killer cells and our T cells and our macrophages. And next, they can also slow down cell proliferation of the tumor cells. And lastly, they can alter the antigen expression on either our own cells or the cancer cells to improve recognition of our immune cells to the cancer. So our immune system have a better chance of fighting it. And then interleukin-2. So apparently we remove the patient's lymphocyte and grow it in culture, and then we sensitize it against the tumor antigens. And then after proliferating it more, we put it back in the body, and so we have a better immune response against these tumors. And then there's the protein kinase inhibitors, which apparently end in inib, and they bind to protein kinase. They bind to their ATP binding sites, so the cancer cells can no longer proliferate because protein kinase is needed in proliferation. Yeah, and some can also apparently inhibit angiogenesis. And these drugs are restricted to selected leukemia and GI tumors. But the problem is that there are also other pathways for proliferation of cancer cells, so they may be able to find a way around this, like without having to use protein kinase or something like that. Yeah, and lastly is sensitizing agents. So BGG is something from like a type of bacteria, and we instill into the tumor that grows inside the bladder lining to make these cells more immunoreactive. So as in our immune system are more reactive to them and are better at targeting them, and induce inflammation. So inflammation, once again, it brings immune response to the site. But the thing is, it can only target superficial cells, so we must instill it repeatedly as we get rid of the superficial layers, yeah, like a layer at a time. And here's some treatment complications in general about cancer chemotherapy. So the first is drug resistance. So this develops through spontaneous mutations of these cancer cells. For example, they may develop like methods to pump drugs out, like they may have transporters that are able to pump these drugs out, so these drugs can never reach like a toxic level and can't really kill these cancer cells. Yeah, or cancer cells can just find pathways around drugs that inhibit DNA synthesis. Yeah, so the strategy to counteract this is multiple cytotoxic drug therapy, so just multiple drug therapy. We use many drugs at a time so the cancers can adapt. Not adapt, I'm sorry. And then, or there's drug holidays. So these treatments are delivered in cycles, and we take breaks between these cycles. And not only is this useful in preventing drug resistance, it actually allows the patients to take a break from all the horrible adverse effects as well. Yeah. So apparently some drug effect in general is due to lyse cancer cells. So when we use anti-cancer cells, we kill some cancer cells, we lyse them, they break, and they kind of like spill their contents to surrounding cancer cells. And apparently this can cause the surrounding cells to die as well. So cell death can still continue even during a break. Yeah, and so some drug therapies work best at certain concentrations for a set period of time, such as short periods of high concentration. And once again, I think I mentioned this at the very start, not all cells are at the same stage of the cell cycle at a time, so we're also waiting for some cells to become vulnerable during this like drug holiday, this break. Yeah, and then there's tumor cell sanctuaries. So it's when tumor cells grow in compartments that's like inaccessible to drugs, and they can be troublesome because they can create sites of relapse. So sometimes some cancers, even just a few cells, can enable a relapse. So to have these sanctuaries mean yeah, the cancer just like we can't get rid of it. So some strategies to counteract that is like radiotherapy or surgery. And lastly is dose exhaustion. So it's like when you're using one drug and you've already reached the maximum therapeutic dose, and any more will become toxic to the body. But at the same time, the patient's immunity can wipe out the remaining cells that hasn't been killed by the drug yet. So once again, the strategies can be multiple drug therapy. We use other drugs with similar mechanisms of action, or we just combine radiotherapy, surgery, and chemotherapy. So yeah, we use just more drugs, and at a lower level, try and target a cancer. Or yeah, we could add more drugs, but keep the doses low. So lastly, these are the core drugs, right? So I took all of this info from ePharm, and it's always hard to know how much you need to like know from that, how much you have to memorize. And I really try and pick out the core stuff. And yeah, so the first one, and I did it by order of how I ordered the presentation, like alkylating agents, cytotoxic antibiotics, stuff like that. And there's 2 pages of this. There's 7 drugs in total. So the first one is cyclophosphamide, is an alkylating agent, and if you remember what it is, it's when you like insert an alkyl group into the DNA. So it's a prodrug that's metabolically activated and delivered by these CYP450 enzymes. You have to know the specific ones. And their metabolites form DNA crosslinks that interferes with cell replication in rapidly proliferating tissues. So this happens, since it happens in rapidly proliferating tissues, you'll find that all the drugs that affect the rapidly proliferating ones will cause problems like myelosuppression. So of course you have lower immunity, and alopecia, I don't know how to pronounce that, but that's like hair loss, and potentially irreversible fertility. So remember, these are all the adverse effects I earlier mentioned about drugs targeting like cells with rapidly turnover rates. And then it's also associated with CNS toxicity, so you feel nausea and vomiting, and some interactions. So since it's metabolically activated in the liver by CYP450 enzymes, of course, there's CYP450 interactions. So any drugs that affect these enzymes will either like increase or lower the level of cyclophosphamide in the body. And apparently with dexamethasone, I can pronounce the effects of this drug, but I don't think this is that important. Next is doxorubicin, so that's the cytotoxic antibiotic. Remember, the endings like this tends to be like antibiotics, and it's got 3 actions. So first, it intercalates with DNA, so this inhibits transcription and replication of the DNA. Yeah, it also binds to DNA and topoisomerase too. So remember, this is enzymes again. So this forms a complex that prevents religation of DNA. So that means when in replication, when the DNA strands split apart, they can't be glued together again. It also generates reactive oxygen species, and these are like in general harmful to the body and can damage DNA. And yeah, so the side effects is once again nausea and vomiting, hair loss, and cardiotoxicity. So it can cause congestive heart failure, and apparently it also has CYP450 interactions. Next is methotrexate. It's an antimetabolite. It's a folate analog. So remember, antimetabolites affect like DNA synthesis and stuff. And this one in particular affects it's a competitive inhibitor of dihydrofolate reductase, DHFR, which is used to convert folic acid to dihydrofolate, and convert that to tetrahydrofolate. And tetrahydrofolate is essential for the synthesis of purine in something called thymidylate synthesis. So in general, what you have to know is that's a folate analog, and therefore it inhibits DNA and RNA synthesis. So therefore it's cell cycle specific in the S phase. And of course, this means that it targets rapidly proliferating cells again. So you'll find all like of the similar symptoms again of myelosuppression and disturbances of GIT. So remember, the GIT lining cells are also rapidly proliferating, so it can cause mucositis and stuff. Yeah, and methotrexate also happens to be a DMARD. like it's an anti-inflammatory drugs. I can't remember if you guys learned it yet. Maybe it's for next sem, but yeah. It not only is it an anti-cancer drugs, it's also used to treat like gout or arthritis, stuff like that. Yeah, and aside from these general side effects that we often see, it also causes hepatotoxicity, photosensitivity, and neurotoxicity. And yeah, so it can interact with other drugs that cause these problems. And apparently these 3 drugs also increase its concentration in the body, but I don't think that's too important. And then there's fluorouracil, and apparently it can also be called like 5-FU or like 5-fluorouracil. And this one is also an antimetabolite, and it is a pyrimidine antimetabolite. Yeah. So basically it also interferes with DNA replication as well. So it's called like in the body as intracellularly converted to metabolites. So there's like all these different kinds that we don't need to know the name of, and apparently some of them can compete for thymidylate synthase, which we kind of like have seen that earlier, and it's just I guess it's just like an enzyme that's needed in DNA replication, or it can also get misincorporated into DNA or RNA synthesis. So it's like all these different ways allows it to interfere with DNA replication. Yeah, and it calls something called the hand-foot syndrome. So that's when like your hand and foot has like swelling and blistering and stuff. And then of course it's the same adverse effects again of like myelosuppression, hair loss, GI disturbances. So you feel nausea and feel like vomiting, or you have like diarrhea. And these are some interactions with other drugs, but once again I don't think this is too important. Next is tamoxifen. So the last 3 are more like the these are all the breast cancer drugs. So tamoxifen is a SERM. So it's a selective estrogen receptor modulator. So apparently this thing in the body, it can either be anti-estrogenic or pro-estrogenic in the body, depending on what the target tissue is. And in breast tissue, it is anti-estrogenic. So therefore, we reduce the growth of estrogen-dependent breast cancer cells. And its adverse effects are kind of like associated with lower estrogen levels. So that's like hot flushes and sweating, and leg cramps, or like increased risk of, apparently it causes a little increase in the risk of endometrial cancer. And it can also cause like leg cramps. And some interactions, once again, is CYP450 interactions. Or like when people are taking warfarin, the blood thinner, it can increase the actions of warfarin. Yeah, and the next is anastrozole. Oh my god, anastrozole. Yeah, it's an aromatase inhibitor. So yeah, it's a non-selective aromatase inhibitor, and an aromatase, in postmenopausal women, it converts androgens to estrogen in peripheral tissues, and so by inhibiting it, we reduce circulating levels of estrogen. So once again, similar to tamoxifens, we reduce the growth of estrogen-dependent breast cancer cells, but it's important to note that this is used in postmenopausal women because it's not the same. Like aromatase doesn't have the same functions in premenopausal women. Yeah, so once again, its adverse effects are associated with reduced estrogen levels. So this is like hot flushes, sweating, vaginal dryness, and reduced bone mass density. So I guess it can cause like osteoporosis and stuff. And then it's the usual GI disturbances. And it doesn't have any interactions with other drugs. And last one is there's trastuzumab. This is a monoclonal antibody, so this is the only one out of all of them that you have to learn that's a novel agent. And you've probably come across this several times, like HER2 receptors. So HER2 receptors is a transmembrane tyrosine kinase receptor that's like overexpressed in breast cancer. So when we bind to the extracellular portion of it, we prevent activation of intracellular tyrosine kinase, and therefore we inhibit the proliferation and survival of HER2-dependent tumors. And its adverse effects are cough, GI disturbances, infusion-related reactions, and cardiac dysfunction, and interacts with other anti-cancer drugs. And that's it for anti-cancer. Remember, if you guys have any questions, you can just ask me.
Okay, hi. Welcome back to yet another episode of PS Pain Relief. If my eyes kind of look weird, it's because I was just watching this one video. Oh my god, this this family gets a bunch of dogs, and they're really cute. And when the baby cries, the dogs start howling, and it's just the sweetest thing. So. Oh my gosh, if you want the link to that video, I can send you the link. But other than that, let's get into wound healing. Cool, fun topic. This is actually the second part of the whole like wound healing topic. You guys would have heard of it in the previous like installment of PS Pain Relief last week. And so yeah, just bear in mind that you guys have learned like I would say 60% of all of this stuff already anyway. Okay, so what are we going to learn today? Today we're just doing some basic concepts. We're also doing the healing of different tissue types and factors affecting the rate of repair of tissues. It's going to be very light today. So yeah, let's just make a start. Okay, so if you remember this diagram from last week, that's cool. If you don't, also fine. So basically, remember that you can have there are many things that can happen to your cells. So it can be constant stress, which can lead to adaptation. There can be cell injury. Cell injury can be reversible, leading to just like normal healing. Here you can see that we're calling it resolution, or the injury can be irreversible, and in that case you would either have scarring, or you would have necrosis or apoptosis happening, and because of that you would therefore have loss of tissue, and this is when our next this part of the lesson comes in handy as a continuation from the previous lesson. You would have a loss of tissue because you would have a loss of a large amount of cells, either by necrosis or apoptosis, and therefore this would lead to scarring, because this loss of tissue is going to be replaced by scar tissue, which is fibrous tissue. So if we could just go on to the next section. So basically, you guys now know that there are different things that can happen to your cells when they get injured. I'm going to go a little bit more in depth into how exactly this stuff happens. That is so vague, but okay. So basically the normal wound healing process is that first you have hemostasis, which is exactly what you guys have learned I think about 2 weeks back. You will also have inflammation, which you guys have also learned about. You would have proliferation, and then you would have maturation. So, well, we don't really get a lot of detail on this in the lecture slides, but I have put a picture right here that's going to tell you guys a little bit more about the different stages. So just very briefly, the hemostatic phase, here it's called something different. Here it's called the exudative phase, but just remember that we kind of call it the hemostatic phase. So basically what happens is that the wound is filled with fibrin, and the blood kind of coagulates, which is hemostasis, the stopping of bleeding. Then after that, you would have what they call here the resorptive phase, but what we call the inflammatory phase, when scavenger cells, or as we know, phagocytes, they would come here, and then they would remove all the dead cells and the germs, and by that we mean like pathogens, and they would really kind of just clean up everything that has been left by the wound, by the injury. And then after that we have the proliferative phase, during which new cells are formed which fill the wound. These new cells, depending on how severe the injury is, these new cells could be the same type of cells that were once removed by the injury, or they could be a different and more resilient, but also probably more rigid and like not non-like malleable cell type if the injury is really bad. And then after which we would have the repair phase, which we would call the maturation phase, during which cells are formed around the edge of the wound, the new skin is created, and the wound finally closes. So that's the picture wrap on our injury right there. So how do we heal different tissue types? So there are different kinds of wounds, and I mean this is the part that I personally find like really cool, just because I do enjoy learning about wound healing. I would have put in a ton of gross pictures for you guys to see. Unfortunately, I was eating mac and cheese at that time, and I just didn't want to think about I didn't want to comb through like Google Images looking for the best looking laceration or like deep stomach ulcer or something like that, although they are very cool, just not when you're eating, you know. So basically, first we have abrasions. Okay, I'm pretty sure everyone here has knows what an abrasion is. I used to get abrasions all the time on my knees. Shut up. No, not because of that, but because when I was a child, I used to go to those like playgrounds with the plastic slides, and I used to like kind of going down the slides backwards on all fours because I just thought it kind of made me look cool. So I would get abrasions from that on my knees as a child. So shut up. And basically what happens is that when an abrasion occurs, you know that you kind of have a layer of skin kind of sloughed off. After that, a scab will form over the surface of the abrasion. So a thin confluent epithelium will form. Again, I really didn't want to get into the pictures on this because I don't know how well you guys would take pictures of wounds at this stage in your career as future healthcare professional. So I was just like, you know, if you want to Google it, Google it. So basically thin confluent epithelium forms. And then after that, the epidermis continues to mature until your skin has completely just healed over. So that's what happens for abrasions. But what about for like clean wounds? Like paper cuts or even surgical wounds. Or this time when I cut myself, I think it was on the edge of my scissors. I didn't even think that there was anything wrong until I saw a bit of blood, and then I looked, and then the next day the whole wound was just gone. I don't know what happened, but here we now know that that was healing by first intention. So basically what happens is when a thin, clean incision occurs, there is exudation of fibrinogen. Basically that's like fibrous tissue that helps to pull the wound edges together. A weak fibrin joint forms, which kind of just pulls the wound edges together. Epidermal regrowth occurs, collagen synthesis occurs, so that collagen is important for strength and elasticity. You guys would have learned that in the tissues session. And then a strong collagen forms in the wound, which eventually kind of just becomes regular tissue. So that is very the prognosis for such a clean wound would be very good, and would heal very well. But for larger wounds, let's say somebody hacks you with a machete, or you get shot or something like that, that is normally healing by second intention. So by second intention, we mean that the wound edges don't approximate. So the wound edges, oh, my elbows just made a weird sound. So the wound edges won't, they won't close together like that. They may be so wide open and so inflamed that if you try and sew the wound together, if you try and suture the wound together, it kind of just mashes together, and it just doesn't look very good. It doesn't have a clean joint like the first intention sort of healing woundy thingy. So because of that, you can imagine that rather than just creating a bridge between the two edges and then whoop, it's healed, we would have to have something that kind of fills in the space in between first, pulls the wound edges together, and then that's when it can go back to normal, or in this case form a scar. And also you can imagine that if there is a really bad wound, you would have severed a ton of blood vessels. So not only do we need to worry about how well the wound edges are going to approximate, we also have to worry about the blood vessels also healing themselves, and the edges of the blood vessels approximating. So for larger wounds, basically in healing by second intention, what happens is that first you have granulation tissue forming, which happens in two stages. So there's angiogenesis. You guys would have heard of this in cancer, but I'm here to tell you guys that this is not all bad. Angiogenesis is important, especially when you guys have a big cut and have severed a bunch of blood vessels. So basically new blood vessels form via the regrowth of the endothelia in the severed blood vessels. So you can kind of imagine that if there's a tube, two tubes that have been severed like that. Sorry, if there's a tube that has been severed like that, something would have to happen for it to be grown back, right? So that's when the endothelia from here would grow this way, the endothelia from here would grow the other way, and then that kind of creates new blood vessels from the severed blood vessels due to the injury. And there would also be fibrinogenesis, which is the proliferation of fibroblasts, which, as you guys know, once again, are your fibrous connective tissue, which is necessary to contract and really pull the wound edge together. Okay, and then after that, you have organization. So what is organization? Basically, your granulation tissue, once it's been formed, it contracts, and you also have an accumulation of collagen inside the wound by second intention. And then after that, once you have like a lot of collagen, you would have an early fibrous scar. And then after that, you would have a scar that is contractile. So sometimes, I'm not sure if you guys have seen or have scars yourself, but sometimes the skin around the scar is like really tight, and that's because scars are contractile. Okay, they really want to get the wound was not able to be closed so easily, and that's why there's kind of like an overcompensation in terms of how much the body wants to pull the wound together. So yeah, that's just a long-winded way of saying that this is okay and this kind of sucks. Okay, so other kinds of injuries. What else can you think of? Well, especially for our second years, we're learning about we did learn about peptic ulcers and gastric ulcers. So what are mucosal ulcerations in the gastrointestinal tract? Well, this involves the loss of full thickness of the gastric mucosa. So one thing to learn is that when you're describing injuries, when you're describing when you're basically describing injuries, it is useful to use the terms full thickness or partial thickness. Okay, so if your stomach lining has a kind of ulcer that damages it, if your stomach has damage due to acid, and the acid kind of burns away a little bit of the top part of the membrane, but not the full thickness of the tissue of the stomach like sac, then that's just mucosal erosion. But if your acid kind of goes all the way through and potentially leaks out and damages other structures in your abdominal cavity, then that's much worse, and that would be a full thickness ulceration. So basically, when just remember that when we talk about injuries, we like to use the terms full thickness or partial thickness. So for mucosal ulcerations, this involves the full thickness of the gastric mucosa. Basically, we've talked about this already. It's hemostasis, inflammation, granulation, tissue formed, and then regeneration of the mucosal epithelium. And why? And you might be wondering, hey, wait a minute, you literally just burnt through the entire thickness of the gastric mucosa. How is it able to just regenerate like that? Well, that's because in the gastrointestinal tract, there are things just passing by all the time. These things may have high pH, they may have a low pH, and basically having a high or a low pH is very damaging to the cells. So in that sense, that's why the cells in the gastrointestinal tract are always proliferating. They're always multiplying, and they're always regenerating. So that's why when you have a full thickness ulcer, there is just a very quick turnover of cells, and you're back to normal, provided that you have some good medicine for that, namely proton pump inhibitors, other sorts of things. Well, okay, and also before I go on too long on that, we have mucosal erosions in the gastrointestinal tract. So this is a loss of the this is a partial thickness loss of gastric mucosa. So basically what happens is that the labile epithelial cells next to the damaged area are able to replicate rapidly because, as I said earlier, everything here is just replicating really fast. There's a high turnover. So you don't even need to wait for that specific bit of damage to kind of regrow itself. The cells around it will kind of like be like, oh, okay, I see this happening, and they'll just kind of grow over that and really fix up the hole that's being created. And this leads to a full regeneration of the epithelium. Okay, and then for fractures, last but not least, what happens is that there is hemostasis because, believe it or not, we do need blood for our bones. I know that when I was in first year, and even if I don't think about it too hard, sometimes I think that bones are kind of just like, a structure and you don't need any form of supply to it. But that's not true because when you have a fracture that cuts off supply to a bit of bone, you can have avascular necrosis of the bone, and that's not good. That is very much not good. So basically, there is blood in the bone, and basically what happens during fractures is that you have hemostasis, you have inflammation, you also have the recruitment of fibroblasts and osteoblasts. Remember that osteoblasts are the ones that create bone tissue. Bone tissue. They produce the bone tissue. So a callus forms. A callus is kind of a callus is not the same as the tissue that was damaged. It's kind of just different and slightly more rigid. So this is where that concept comes in, where if there's damage in something that's not that doesn't multiply rapidly, then you could just have a regrowth of a different cell type that is a lot more rigid, a lot stronger. So you could have a callus forming, and then the cartilage in the callus is slowly replaced by bone, and this allows the fractured area to be remodeled into new bone, into normal bone. Which usually happens unless the damage is way too severe. And in that case, you would just have to have like plates put into your ankles and stuff like that. Scary stuff. Okay, and then last but not least, as I said, this is not a big lecture. So factors affecting the rate of repair would be infection, nutrition, glucocorticoids, mechanical variables, poor perfusion, foreign bodies, location of injury, and aberrations of cell growth. We did not get a lot of detail into this stuff, but you can kind of logic it out. If there's an infection, your cells are just, all their energy is taken up by, having to fight the infection as opposed to being able to heal the wound. And then the pathogens will probably be constantly just feeding on the tissue in the wound that is proliferating, and then that's just not going to contribute to good healing. If you don't have nutrition, you need vitamin K to form a lot of your blood clotting factors. So if you don't have enough vitamin K, if you don't have a lot of other kinds of vitamins, you guys aren't going to be able to, not you guys, but basically anybody who has a wound is not going to be able to form clotting factors, not going to be able to form, to undergo hemostasis, and then, you just can't really go through the rest of that chain of events. So glucocorticoids are a very interesting case, which you guys are going to touch on in the next part of this year. So they are, I believe they fight inflammation, unnecessary inflammation. They also help with pain relief, so that's some good stuff. But you guys are going to learn about that at the end of this year, so I'm not going to confuse you guys with that. There's mechanical variables. So if let's say I have a wound on my forehead, right? I mean, how often do I move my forehead around? I'm kind of, my eyebrows don't move a lot. But let's say if I have an infection on if I have an injury on my elbow, then that's going to be really pesky, because, you can see that my elbow does that, and then it does that, and then, it is in constant motion. It is an area that is experiencing a lot of either stretching or compressing and stretching and compressing. So that would not lead to good wound healing, whereas some part of the body that doesn't really get a lot of that shearing force would heal much better. So yeah, that too. And then poor perfusion. Poor perfusion, basically, remember that everything that's happening to your cells requires oxygen, requires other cell mediators, requires signals and stuff. And all of this has to be transported by blood. So if you don't get a steady bloodstream to that area, then you aren't going to get the necessary materials that you need to heal that area, and healing is not going to happen. Also, foreign bodies, if you have a grain of sand stuck in your wound, that is really gross for one. And again, it's going to hinder the approximation of the wound edges, so that's not good. Location of injury, I think that may overlap a lot with mechanical variables, but location of injury also has to do with the cell type that has underwent the injury, and then aberrations of cell growth. There might be some people whose cells, they don't grow so well or so fast. And yeah, I mean, like I said, you guys don't need to know a lot of detail on this. Just know that this affects wound healing. Okay, and I am also doing microbiology. And lucky for you guys, this is not a big topic. In fact, this is supposed to be, this was supposed to be an active learning. And I kind of think that it's not super necessary, but still do learn it. Yeah, I'm sorry. Okay, so basically what are we doing in this segment? We're doing hand hygiene, we're doing the diagnosis of microbiota, and we're also doing some common microbes, which you guys might touch on in this active learning. So well, I don't need to tell you guys why hand hygiene is important, especially now during this like pandemic, but just in case it hasn't been hammered home enough for you guys, hand washing is important because because when you use soap, there is a massive reduction in microbial numbers. It removes transient flora and most others, and it and the downsides of that are that Staphylococcus epidermidis, oh my goodness, I cannot speak. Staphylococcus epidermidis will prevail. It's still there, and it's not good for gloved hands going into a surgery for many hours. So hand washing with soap, it's good. It removes the bacteria that are not part of your natural flora, but it's not good if you're going into surgery and you kind of need you need to be sure that you're not introducing anything horrible into the person's like insides. So that's when you need your chlorhexidine wash. It's good for skin antisepsis before surgery. So once again, what is used when? So at home, it's fine to just use soap and water, right? You don't need to be kind of scrubbing up and doing like chlorhexidine hand wash and kind of going into a hazmat suit with the spray thingies, in those alien movies where people get sprayed when they come out of the. Okay, well, I'm not sure if anyone's watched Arrival. That is a good movie. That is a very good movie. And you see them getting kind of like sprayed down when they come out of the alien spaceship. You guys don't need to do that when you come home. Obviously, just use soap and water. In a clinical setting, again, you guys aren't going to have to do that every time you meet a new patient. You're just going to need to use your alcohol hand rub, which you guys will. Oh, you guys haven't seen Med Building. You guys will see in abundance in the Med Building, and it's this delightful bright pink color that you guys are going to love. Yeah, unless you really hate pink for some reason. Okay, and then in a surgical setting, you guys will either be using actual chlorhexidine hand wash, or you will be using povidone iodine, which I personally haven't seen a lot, but then again, I've only been to an emergency room for like 10 days, so that's not a lot of time, but I did not see the povidone iodine used, only chlorhexidine. And this is a mind map that you guys are going to see in the prac. Basically, this is how you diagnose what type of bacteria is causing the infection. So normally what happens when you suspect an infection, you will need to run some blood tests. You would need to culture the bacteria, right? So usually when we tell you guys about bacteria, we describe them as being either gram stain positive or negative. Here we have, if it's gram stain positive, it can be cocci or bacilli, which are rod-shaped. Cocci are kind of, they're kind of more rounded, I think. Yeah. So I'll talk you guys through the catalase test later on. Basically, if it tests positive for catalase, it means it's a staphylococcus. It's a staphylococcus type of bacteria. If it tests positive for coagulase, that means it's Staph aureus, which is the answer to like 80% of your microbio MCQ questions, just in case you guys want to know a shortcut. If it's a coagulase negative, it can be this number of bacteria, but it doesn't really matter that you guys don't know that. If it's catalase negative, then that means it's a streptococcus, okay? So it could be a strep. So that's when you go through the hemolysis test. The hemolysis test can be green, can be clear, or can be, there can be no hemolysis, right? So this is when you have your different types of strep. Yeah. Once again, this is way more detailed than you guys actually need to know, but just remember the important ones like Staph aureus, and as we'll go on later, Vibrio cholera, and yeah. Okay, so here are two very common microbes. So Staphylococcus aureus, as I mentioned earlier, it's usually the answer to a microbio question. So it tests positive for the catalase test. So Staphylococcus aureus has catalase and will therefore produce gas when hydrogen peroxide is added to the culture. It will produce H2O plus O2. Yep. So also, Staphylococcus aureus has coagulase. So coagulase, yeah, it has coagulase, which converts fibrinogen into fibrin. You guys would have learned about coagulase, fibrinogen in the hemostasis, lecture that we did earlier on. So yeah, that's about it for Staphylococcus aureus. Obviously, this is just from the prac, and that's why it's not super detailed. This is just in case you guys are going into the prac this week and want to be a bit more prepared. So I'm so sorry that it's not super detailed. Okay, anyway, Vibrio cholera. It's curved, it's rod-shaped, and it has a flagella, and it's gram negative. So what are you gonna do? You're gonna put it onto the TCBS agar. So T is thiosulfate, C is citrate, B is bile salts, and S is sucrose. So thiosulfate, citrate, and bile salts. If you put them with a gram-positive bacteria, you would get nothing because they inhibit the growth of a gram-positive bacteria. But if you put them with a gram-negative bacteria, just like Vibrio cholera, you would get little colonies forming on your agar plate. So that's good. Yeah, that means that you have Vibrio cholera. Okay, obviously it's not good to have cholera, but it means that you know that it's cholera, which I guess that's good. So the S part of the TCBS agar, that's sucrose. So Vibrio bacteria can ferment the green coloration of the sucrose that they add into yellow. So you will see in a sea of green a bunch of yellow colonies that have been growing on the agar. So that means that you have Vibrio cholera. And that's all I have for you guys today. I hope you guys have enjoyed our PSP for the past 10 weeks. It's been a wild ride with you guys. And once again, if you guys liked If you guys like this, please subscribe to our channel. Please also like this video. And don't forget to join our Facebook group. Don't forget to DM your questions directly to us. And we will see you next time on another episode of PS Pain Relief. Thank you so much. Bye.